books, including Teen Sprite, Girls and Boys. So over to Deepa to take us forward.
Thank you, ma'am. So good morning again. So my topic for today is premenstrual syndrome and premenstrual dysphoric disorder. Let's start with the case. We have Ananya, 16-year-old girl, a class 11 student, who reports bloating, breast tenderness, irritability, mood swings, and poor concentration starting 5 to 6 days before her periods, resolving soon after menstruation begins for the past 6 to 8 months. The symptoms disrupt her schoolwork and relationships. Her menarche was at 13 years, she has regular cycles, and her BMI is appropriate. There is no chronic illness, though her mother recalls similar complaints in her adolescence. So what are premenstrual disorders? It's actually a spectrum starting from premenstrual syndrome to premenstrual dysphoric disorder. It's characterized by physical or psychological symptoms or both. And it occurs in the luteal phase of menstrual cycle. This is very important. The timing is the one that differentiates. It occurs in the luteal phase of menstrual cycle and resolves with the onset of menses. It has a negative impact on psychosocial functioning of the affected individual. Now, what's the pathophysiology? To be very frank, it's unclear. But the theories proposed is the heightened sensitivity to the hormonal fluctuations during the luteal phase of menstrual cycle. Why? Why? Because these fluctuations happen in every female during the reproductive cycle, but not everyone gets this premenstrual disorders. So, because these people have a heightened sensitivity to the hormonal fluctuations of estrogen and progesterone. Another theory is proposed is that when the estrogen levels drops during luteal phase, it it affects the serotonergic system. Another one is the aberration of the progesterone. The progesterone has a metabolite called as allopregnanolone, which is a neurosteroid. That has got a calming effect through GABA. And when the progesterone level drops in luteal phase, it causes a decrease in allopregnanolone, a decrease in the GABA calming effect, leading to premenstrual disorders. Now, when you compare PMDs with other mental health or medical disorders, how do you differentiate? Basically, it's the timing. It happens in luteal phase, symptoms occur in the luteal phase and resolves with the onset of menses. And secondly, it must affect individuals' psychosocial functioning and should cause distress. In detail about premenstrual syndrome, it occurs in about 30% of adolescent females. Symptoms include mood changes, bloating and breast tenderness. It begins in the luteal phase of the menstrual cycle and improves within a few days of the onset of menses. And how do we diagnose? As per ACOG guidelines, the common symptoms include psychological, physical or both, as I said. And the most common psychological symptoms include fatigue, irritability, mood swings and depression. And physical symptoms include abdominal bloating, breast tenderness, acne and changes in appetite or food cravings. There is no minimum required number for the diagnosis, no minimum symptoms, and symptoms must occur cyclically in the luteal phase of the menstrual cycle and must resolve after the onset of menses. How do we manage? It's basically a multimodal approach. Lifestyle interventions, exercise and stress reduction may help. Severe symptoms requires cognitive behavior therapy. Vitamin B6 and calcium for adults, they recommend calcium supplementation. For adolescents, they say calcium can be given as per the required dietary allowance. Calcium helps by helping with the neuroirritability and also the vascular reactivity. And combined hormonal contraceptives we can prescribe for those adolescents who also have dysmenorrhea, acne or contraceptive needs. Now, premenstrual dysphoric disorder, this is more rarer and more severe condition, affecting 2 to 5% of the menstruating females worldwide. It causes significant distress and functional impairment, maybe accompanied by physical and behavioral symptoms. So it's a distinct treatment responsive depressive disorder. So that's a good part of it. It's responsive to treatment. An accurate diagnosis requires use of a menstrual calendar to prospectively document cyclic symptoms. So we ask them to come again with a menstrual diary for the next 2 consecutive months. So what are the risk factors for PMDD? Anxiety or depression? Premenstrual symptoms, another risk factor. A family history of premenstrual syndrome, premenstrual dysphoric disorder or mood disorders are also risk factors. And personal history of trauma, abuse or other highly stressful events. So to screen, we have a screening tool called as premenstrual symptoms screening tool for adolescents. And for diagnosis, we have the DSM-5 criteria. The first, it has A, B, C, D, E up to J, G, and A is basically the timing what I had already mentioned. From B and C, you need at least 1. and together B and C should be fine. And D goes for it's causing clinically significant distress. And E is the distress is not merely exacerbation of another condition, maybe depression or anxiety. And EF goes for it's confirmed by prospective daily readings in the menstrual cycle for at least 2 cycles. And the last, it should not be attributed to any drug or substance abuse. Now, how do you manage? Initial management goes just as what it goes for PMS, plus for PMDs we require SSRIs and as a first line drugs. And SSRIs can be prescribed either continuously or intermittently. Intermittently you do it, that is when the symptoms start, you start prescribing, and when the symptoms is over, you can stop. So that is an intermittent way of prescribing SSRIs. You can give fluoxetine 20 mg once daily. And for adults who need contraception, the tresprenone 3 mg and ethinyl estradiol 0.02 mg combined pill delivered for 24 days, followed by 4 inactive days, has been approved by FDA for PMDD. Now, what are the complications? Depression, and in severe cases, suicide can happen. Severe emotional distress can happen, and it can negatively affect relationship and careers. Prevention. Treating existing depression or anxiety may make it less likely that PMS could become PMDD. And what's the prognosis? Any idea? Usually it goes in only with menopause, but it's response to treatment. So symptoms more severe in women's 20s to mid-30s and gradually subsides around menopause. Effective treatment, especially for severe cases, is key to a good prognosis. Now, what's the difference between premenstrual disorders when it goes to adolescence? When we compare adolescents and adults. In adolescence, the onset often begins a few years after menarche, whereas in adults, it can begin later or can start in adolescence itself. The main symptoms in adolescence may be irritability, anger, behavioral issues, and school disruption. When it goes for adults, it is depressed mood, anxiety, affective lability more prominent. And cycle features, we all know that physiologically, the initial cycles are irregular in adolescence, so the diagnosis becomes more difficult. Whereas in adults, being more regular cycles, it's easier to diagnose. So what are take-home messages? PMDs include premenstrual syndrome and premenstrual dysphoric disorders. Symptoms are both physical and psychological. They occur during the luteal phase of menstrual cycle. PMDs can negatively affect a person's daily life and psychosocial functioning. Lifestyle changes, pain relievers from the first-line treatment, and severe PMS and PMDDs require serotonin reuptake inhibitors. Thank you.